Some highlights of Japan's Bismarck model include that Japan uses a universal healthcare system that is mandated for all residents, ensuring that everyone has medical coverage and making sure no one is denied care because they cannot pay. They also use a fee for service payment model that the government regulates to control costs and ensure affordability for all its citizens. Japan's healthcare system also relies on patient copays that vary anywhere from 10% to 30%, in which the insurance covers the remaining 70%. These rates, of course, vary based on income and age. Patients also have the chance to choose their own physicians or facilities of their choice, and they cannot be denied coverage due to any pre existing health conditions. Japan does have three main categories of health insurance plans, whether it is employer based or they offer the Citizens Health Insurance Plan, which applies to those who are retired and self employed. In this case, the premium costs is split between the individual and the local government.
The key policy characteristics of the Bismarck model are made possible by a foundation of shared values and ethical principles that shape how society views health, responsibility, and fairness. These values make people willing to pay into the system, accept regulations, and ensure universal access to healthcare. On the next slide, we will see how the Bismarck model is ethically consistent with the ANA Code of Ethics. In comparison, solidarity and universal access to care corresponds to Provision 8 and 9, with Bismarck's commitment to mandatory insurance and universal care supporting the ethical duty to promote health for all people, especially the vulnerable. Human dignity and equity aligns with Provision 1 and 3, with respect of every person's dignity and right to care. Shared responsibility is corresponding with Provision 2 and 8. The social partnership in healthcare puts emphasis on collective responsibility and collaboration for community health. We can also see Provision 6 and 7 with the government overseeing cost, quality, and fairness, which aligns with the ethical duty to create safe, just, and a sustainable system of care. Patients' autonomy goes along with Provision 1 and 3, which preserves personal dignity, autonomy, and trust.
This slide highlights how health policy differences between Japan and the United States shape national outcomes and equity. In Japan, universal insurance ensures everyone has access to care regardless of income. The United States, by contrast, ties access to insurance, employment, and socioeconomic status, which creates large gaps. Japan achieves world-leading life expectancy and lower infant mortality through prevention and primary care, while the United States sees more chronic disease and preventable deaths despite far higher spending. Japan's system emphasizes equity and collective responsibility, whereas the U.S. model focuses on treatment and profit. As Reed explains, Japan's standardized coverage and early intervention policies help produce stronger, more equitable population outcomes. Policies shape social justice and population health outcomes. Japan's system distributes care and costs collectively, reducing disparities. In contrast, the U.S. model often prioritizes treatment and profit over prevention, creating gaps in access and fairness. Reed also highlights this imbalance, noting that our country spends too much on healthcare and gets too little in return. Japan gets lots of healthcare, but probably spends too little to make its excellent system sustainable. This quote reinforces that both over and underinvestment affect health equity, showing how policy and economic regulation directly shape outcomes. Overall, Japan's cohesive, equity-focused approach produces fairer and healthier results than the fragmented U.S. system.
Japan's health system treats universal health coverage as a moral imperative, supported by nonprofit insurance. It's financed through a national fee schedule with government set prices, ensuring fairness and cost control. A societal expectation, an individual mandate, requires everyone to be insured, promoting shared responsibility. This societal responsibility aligns with the ANA Code of Ethics. Provisions 8 and 9 call on nurses to collaborate, reduce disparities, advance health equity, and advocate for justice. These values embody Japan's model of equity, solidarity, and access, not commodification. We can achieve this by replacing profit-based competition with regulated fairness. Every insurer contributes to a shared risk pool, while the national fee schedule limits prices. This cuts administrative waste, keeps premiums stable, and protects both patients and providers. Change can begin at the state level. Washington's Cascade Care reduces coverage gaps by providing universal access through a public option and automatic enrollment, while Maryland's all payer and total cost of care models set fair, uniform payment rates. Support would come from those who value prevention and cost stability, like nurses and employers. Opposition would arise from those defending high margins, like for profit insurers and the pharmaceutical industry, and from market individualism, the ever entrenched American belief in self reliance, competition, and minimal government control. Let's start now. It may feel impossible, but incremental state based reforms like Maryland's and Washington's are already proving effective. If we apply Japan's tools through these pilots, we may not see perfection, but we can still see meaningful change in our lifetime.
Thanks to the ANA Code of Ethics, nurses have shared values. For example, from the ANA website, nurses and their professional organizations work to enact and resource practices, policies, and legislation to promote social justice, eliminate health inequities, and facilitate human flourishing. These shared values should inform nurses' political perspectives. What nurses can do with these shared ideals can be seen in California's nurses' unions, where they are lobbying and doing advocacy work, contributing to campaigns, electoral mobilization, and also doing public awareness campaigns. Nurses have made immense contributions as leaders in practice and policy issues. They successfully lobbied for the nation's first comprehensive law to prevent workplace violence against healthcare workers in 2014. They championed efforts for more robust protections during public health emergencies like the COVID-19 pandemic, played a key role in defeating Republican candidates in gubernatorial races such as like Meg Whitman in 2010, and supported the campaigning of other candidates like Jerry Brown. They've organized to support and pass ballot initiatives such as Prop 50 this year. So how do we keep it going? We've got to educate, so it's important that all nurses at every level, LVNs, associates, bachelors, learn the ANA Code of Ethics. Then we've got to organize and unionize. It's really important given that hospitals, pharmaceutical companies, etc., are all serving their own interests. We need to use our collective power to continue to advocate for patients and our shared values. We've seen how powerful nurses can be when they organize. And then we need to use that power to impact not just national policy changes, but also local changes.